All right, let's go ahead and start going through this. So we have some different scenarios here, and then that give you the opportunity to get into your resources and see what's what for these patients. Okay, so our first one here, we have patient A. They're 72. They had a stroke. Okay, so by now we know that means that on one side of their brain they either had a bleed or a clot. Either way, oxygen is not perfusing, so that tissue starts to die. So whatever it was responsible for, they lose that function. Okay, so it could be cognitive or it could be musculoskeletal. Okay, so a lot of times we'll see those patients who have these signs and symptoms that we're seeing. So the weak gag reflex, so they don't really have that sensation where they know something's in their throat that they're swallowing, so they can't control the movement. So they can choke on it, they can aspirate, it can go into their lungs, right? They can be pocketing foods, again, just because they don't have the nerve function, the muscle function to move the food in their mouth like they should, so it can get stuck. That's what pocketing means, it gets stuck in there. So again, anytime, maybe it's been hours since they ate and all of a sudden you're rounding and they're choking in their room because they've been pocketing food. Okay, and then coughing during meals, or like during when we give meds or anything, when they're swallowing their pills, we would assess for that. Again, means that it's going down the wrong pipe, okay? So for whatever reason, they can't control it, so they're having difficulty for that. Okay, so who came up with the term, so their nutritional need or the problem, what's the name of the problem that this patient is experiencing? Anybody come up with that? It starts with a D. Yeah, dysphagia, Karen, it's dysphagia, okay? So your problem that you should have identified is dysphagia, which is difficulty swallowing. Okay, it's dysphagia, is difficulty swallowing. We talked about dysphagia when we did communication, that's difficulty speaking, either understanding or expressing speech, okay? So dysphagia with an S has to do with speech and communication. Dysphagia with a G has to do with swallowing, eating, drinking. Okay, so that's the main problem. So who can tell me what kind of diet this patient should be on? Addie?
Mechanical soft.
Yeah, mechanical soft, or maybe you have pureed. They're kind of the same thing, but not just regular food, okay? So some type of ground up pureed diet they would be on, okay? And then what else with their diet? There's another part to it, Samantha?
Thickened liquids.
Yeah, thickened liquids, okay? So we have regular liquids, right? Just plain liquids. But in the nursing home, you may have seen it. In the hospital, you'll definitely see it. We have patients who are put on thickened liquids. In your book, you read about there's like honey thick or nectar thick or different consistencies. And what is the name of the professional that comes in and sees our patient and talks with our patient and does tests with our patient to determine what type of diet they should be on? Can anybody tell me? Grace? Yeah, speech language pathologist or a speech therapist. So we've talked a lot about PT, OT, okay, we also have ST. So in our hospital, I think all the Ohio Health systems, they're the ones in the maroon scrub. So like what Caitlin or Grace or Virginia have on, if you see them at Ohio Health, those are our speech therapists. So with PT and OT, we have the therapist who comes in and does the initial assessment, but then otherwise the people who are doing the work that you see are OTAs and PTAs, so they're assistants that are carrying out that plan. Speech therapy doesn't have a speech therapy assistant, they're all STs. So the ones that are in there working with the patients are speech therapists, they don't have STAs for that. Okay, so we're gonna be pureed, thick and liquid, and so what are some examples of foods? Anybody wanna tell me what they came up with? Somebody different, Jeffrey?
Pudding, mashed potatoes.
Yeah, pudding is one, mashed potatoes. If we do give them some type of meat, it would be pureed, ground up type of meat. What were you gonna say?
Applesauce.
Yeah, applesauce would be good, okay, and then they can have juice and things like that, but it would need to be thickened. So in the hospital setting, we'll see containers that come up already made, thickened how they're supposed to be, or there's powders that we can add, and you just read, you know, this is the amount in ounces that I have in my glass, this is the consistency that I want it to be, so I add 1 scoop or 2 scoops or whatever it is, and then you would mix it up, and then it's the appropriate thickness for that patient. Okay, so mashed potatoes, ground meat, a juice that's got some thickener in it would all be appropriate for this patient. All right, and then one nursing intervention. Somebody different want to tell me? Krista?
Make the patient stand up in the bed properly, not like laying down.
Yeah, okay, so again, for all of our patients, but especially if they have dysphagia, always make sure that they're sitting as high as they can tolerate, or if at all possible, get them up in the chair for their meals so that they're already sitting upright. Okay, anything else in nursing interventions? Elizabeth?
Maybe assist them with feeding.
Yeah, maybe assist them with feeding so you can be there and monitor and make sure that they're swallowing okay. Anything else? Nicole? Yeah, staying up for a little bit, so that's gonna help keep things down, and then it's also gonna help avoid developing GERD or acid reflux, because we have that lower esophageal sphincter, that muscular ring that keeps our contents in our stomach. But if we're always laying down after we eat, the stomach acid is gonna brush up against and wear away against that muscle, and it's gonna erode it and break it down, and so then they're gonna have the heartburn and the reflux and different issues like that. Anything else? Did you read about different ways to help make sure your patient is swallowing correctly? Did you read about any of that? So like the chin tuck, so like tucking their chin down to kind of cut off that airway and help move the food. We can have them do like a double swallow and make sure they're clearing all the way, all of those types of things. So chin tuck is a big one, and then having them positioned upright are good. Okay, and then what's the one main risk that we're gonna monitor? It's a word that starts with an A. Yeah, Kennedy's got it, it's aspiration, so that's the main risk. Okay, so some vocab we made sure we learned today is dysphagia, and then aspiration means choking. Okay, and then it also means to pull back on a syringe, right? So when we're checking placement with our tube feeds, with our PEG tube or an NG tube, we aspirate or pull back on the syringe to check the contents. Okay, but in this situation, aspiration means choking. Okay, and it means that it's going down the wrong tube. The trachea lies right alongside the esophagus, so aspirating means that it's not going in the esophagus, it's going down in the trachea. All right, good. All right, patient B, our scenario here, we've got a 58-year-old, they've got heart failure, they're having some edema, which is swelling. Their sodium is 148. So what's our normal sodium range? Did you guys look that up to figure out if that was normal or not?
Between 135 and 145?
Yeah, so it's 135 to 145. So their sodium level is elevated. And then BNP, we've talked a little bit about here and there. It's called the B natriuretic peptide. And it's a hormone that's thrown off when the heart is in distress. So it's specific to our heart failure patients. So in clinical this week, if you have a heart failure patient, you should note what their BNP is and what it was when they came in. And then hopefully of days of monitoring and medications and not letting them eat all the bad stuff they're eating when they're at home, and making sure they're taking their medications like they're supposed to, like maybe they're not doing at home, we should see that BNP come down, okay? So, what's our main problem? It's in the scenario, but what's the main problem or the concern that we're worried about for this patient?
Fluid retention.
Yeah, fluid retention or just heart failure. Okay, the problem is heart failure for this patient. Okay, so when you have, when you're diagnosed with heart failure, just like if you're diagnosed with diabetes, that means a whole bunch of things as far as interventions and education and medications and intake and output and all of those things. Okay, so heart failure is the main problem. Okay, so when they're admitted with heart failure, they're put on a specific protocol. They'll be on limited fluids. We used to have, depending on where you worked, we put them on chips, which means that they can only have ice chips because that helps their fluid intake last longer, because ice chips, you know, if you give them like an 8-ounce cup of water, they're gonna drink it real quick, but if you give them an 8-ounce cup of ice chips, they're gonna take one and chew on it a little bit. It's gonna kind of last longer. So that's a way of keeping them not feeling as deprived, but still keeping their intake low, because we have to limit how much they are gonna take in. Okay, so that's the problem. What's the diet for this patient? What did you come up with?
Low sodium diet?
Yeah, low sodium, or you might see it as a cardiac diet, and a cardiac diet is a low sodium heart healthy diet. Okay, so but low sodium is what we would be looking at for this patient. So no added salts, definitely not giving them table salt, and then the foods that they're choosing. So in the hospital, if they're on a regular diet, there's no restrictions, but they still need to follow the MyPlate. That's a regular diet. So fruits, vegetables, grains, dairy, lean protein, all of that is the MyPlate. That's a regular diet. Whereas if they're on a low sodium diet, there'll be specific foods that their dietary person won't be allowed to order for them because they're too high in sodium. Okay, and foods that are high in sodium are all the packaged processed foods. Okay, so anything that comes in a package is loaded with sodium. It's meant to preserve it and keep it lasting forever, which is good for the people who own the food companies, but not good for the people who eat that food. Okay, so anything that's packaged, processed, any fast food is loaded with sodium. Because if that food goes bad, they have to throw it away and they don't make a profit. Okay, if we load it with sodium, it preserves it, never goes bad, it's not good for you, but they can make lots of money from that. Okay, so low sodium diet. So what are some foods specifically, somebody new we haven't heard from, that wants to tell us specific foods on a low sodium diet?
Steamed vegetables.
Yeah, steamed vegetables would be great. Okay, so vegetables are great. The best form of vegetables is fresh. That's always gonna be the best. After that is frozen. Worst is canned. Again, because it has to last forever, so they don't have to throw it away, so it's gonna be full of sodium. You can find low sodium versions, but it will still always be higher than a frozen or a fresh version. Okay, and again, that's hard to do, right? Because you have to plan ahead, you have to grocery shop like every day. It's much easier to buy the unhealthy stuff. It's cheaper and it lasts longer, you don't have to worry about it. But then when you think about what it's doing in your body and the potential health outcomes for you in the long run, are you really saving or not? Okay, so vegetables, what else? What do you think, Jordan?
Fruits and whole grains.
Yeah, fruits, whole grains. Okay, and then what about meat? If we have to do protein, what kind of meat should we avoid? What kind of meat should we encourage?
Avoid red meats.
Avoid red meats, okay, because those are not going to be as good for your heart for you. So what kind of meats do we want to encourage? Lean meat, so like fresh fish, and then like grilled chicken are going to be your good options. My husband and my daughter are allergic to chicken and fish, so that's out. Okay. All right, interventions. We talked about this a little bit already, so who wants to tell me what interventions you came up with for this patient? So shy today. Yeah, so interventions, so because of the fluid overload, and we know that they have trouble moving fluid already because of the heart failure, they would be on some type of fluid restriction. Okay, yeah, and then for any of these patients, we're gonna pay attention to positioning because we don't want any of our patients to choke. Okay, and then just right along, piggyback with that low fluid is just again monitoring I&O. Okay, so we're always gonna monitor I&O. So it's important to keep track of what's going in, what's coming out. Okay, and a lot of times we won't realize that we need to monitor I&O until our patient's already in distress. So all of our patients in the hospital should be on intake and output. It's part of your clinical packet to be monitoring that every hour, and it should be documented in the chart. Okay, so intake and output. If your patient's getting up and down to the bathroom or the bedside commode and they don't have a hat in there, that's something that you can go get. You go get it out of your bedroom, which you toured this week. A hat is just like that plastic cylinder that's got the measurements on it. You can put it in the toilet, put it in the bedside commode, and then you can get an accurate measurement of what your patient is voiding. Okay? And then the main risk then, again, we've already said it, so what's the main risk for this patient that we're worried about? Heart failure, and what's the symptom, the sign that we're gonna see? Fluid overload, yep. So fluid overload, so even though we don't think about this, a daily weight is the most reliable indicator of our patient's fluid status. So maybe in your job, you've taken weights before and you've been like, well, I hope that's probably not very accurate. I really kind of whomped that up. Okay, but in perfect NCLEX world, our weights are accurate and they're taken at the same time every day. And that is the most reliable indicator of a patient's fluid gain or loss, is monitoring that daily weight. Okay, also we're gonna look at I&O, we're gonna do lung sounds, check for edema, those types of things. All right, so the main thing we're worried about is that fluid overload worsening. Okay, so I still remember when I worked night shift, I had just started here and I was still contingent, and I worked here during the week, so I would pick up weekends and holidays, but then eventually I was like, why am I doing this, Angie? You don't need to do this, so I stopped doing it. But I remember a patient who had her light on, and her BMI was probably, I would say, maybe 39 in that range, and she was there for heart failure, and she was swelling, and she had to go to the bathroom, because we were giving her diuretics, right? She had her colic, she had to go to the bathroom. So we went in there, me and 2 other people, we got her up, we pivoted her, we got her to the bedside commode, she voided, we got her back up in her bed, got her all comfortable, gave her her colic, and she asked me for a bag of Fritos for her snack, okay? Did I get her that bag of Fritos? Or did I educate her and explain to her, what are we doing here? No, you can't have Fritos. I'll go get you some Jell-O or a popsicle or something else, okay? So just thinking about those things and what they do in our patient's body, you know, and providing her with that education. It is not cheap to be in the hospital. Your bag of Fritos is gonna keep you here even longer. So let's think about some other alternatives, and what's that gonna end up doing in that patient's body, right? All right, patient C then. So I've got some numbers over here. So if you guys wanna help me fill in my chart here. So that less than 18.5, what category is that? What word should I write next to that? That's underweight, okay? So they are not getting enough nutrition. Okay, you're gonna see like brittle nails, broken hair, skin's gonna have trouble, they're gonna have like sunken eyelids, they're gonna be anxious, maybe their vitals are gonna be off, okay, they're gonna have issues from being under that normal BMI. Okay, what's 18.5 to 24.9? Okay, that's healthy, that's a healthy weight. Okay, the BMI scale is very unforgiving. Okay, and then 25 to 29.9, what is that called? Okay, that's called overweight. Okay, and then 30 to 39.9 is obese. And then over 40 is morbid obesity. So strongly contributing to illness and death over this 40. Okay, so as you start to become familiar with these, if you got into Epic this week and looked at any patients, right there on that header where it tells you, you know, what their room number is, who their doctor is, when they were admitted, it shows you their BMI. Okay, so you can kind of get an idea of what that patient's gonna look like before you go in the room. Okay, I remember, again, when I did home health still, I would go see this patient, and she was a psych patient. She took like 20 different psych meds, a lot of stuff. But she was also an obese patient. She was also a diabetic patient. Okay, so after one of her doctor's visits, I went and I was helping her reset up her medications because she had some medication changes. We were going through her after visit summary, and she said, that doctor called me obese. Can you believe that? Can you believe they said that? Okay, and that was a time for education because these are not subjective terms. This is not my opinion or me judging my patient. These are medical terms, and once we get into the overweight, obese, morbid obese, it puts them at risk for diabetes, for heart failure, for hypertension, for stroke, for all of those conditions. And so I had to say, well, yes, Mrs. So-and-so, you know, your BMI is this, so you are obese. And she kicked me right out of there, as she did sometimes, but I was still her favorite, and she remembered that she loved me, so she said, send that Angie back here, I'm sorry, I just got upset. Okay, so I came back, and so we went through her medications and her after visit summary, okay? So those are not subjective terms, they're medical terms, okay, and they lead to risks for chronic conditions. Okay, so our patient C, we'll just go through this one, then we'll take a break. 45, she or he doesn't say. They have a BMI of 33, so that puts them in the obese range. They have an elevated LDL, it's at 170, okay, so it should be below 150, and they have a sedentary lifestyle. Okay, so what's this patient's main problem? Is obesity, okay, so that's the main problem. What's the next question? What's the most appropriate diet for this patient? Low fat, heart healthy, yeah, low fat diet. Okay, so just we need to be aware of what foods have lots of fat in them, and what foods need to be avoided. Okay, so a low-fat diet. So avoid saturated fat. So like the red meat, cheese has a lot of fat, some dairy. Okay, so we'd be looking at food labels, we'd be coming up with a plan. Okay, but for patients like this and for everybody, the best thing is to not focus on what you need to restrict, but focus on what you need. Focus on what your body needs. So fill your plate with the things that your body needs, and then it's full and you're full, and you don't have to worry about, oh, I can't have this, I can't have that. Okay, so we want to help them focus on things that they can have and things that they should load their tray with. All right, and so what are some examples of some foods from your resources that you found that we would tell this patient, these are the things that you should put on your plate? Amy?
Our person a salad, salmon, and an apple.
Yeah, salmon's really great, an apple, salad is really good. Okay, so vegetables, whole grains, lean meats. Okay, so a lot of this is gonna start to become repetitive for you. All right, and then intervention for this patient.
Assist with mobility.
Yeah, assist with mobility and then encourage mobility, right? Activity, because they have a sedentary lifestyle, which we all know means not active. So it wouldn't take much for this patient to notice some improvement. So just adding a couple vegetables and fruits every day that take the place of some cookies or some potato chips, instead of sitting all day, doing a 30-minute walk, in 1 week, that patient's gonna notice a difference in how they feel and how they look, just for making those little changes, okay? Okay, and then the education. So like I said, what I did for my home health patient, it's just education, letting them know, this is why you're feeling this way, this is why we're seeing what we're seeing. If you make these changes, we can turn it around. Okay, and then what's a main risk? What did you guys come up with that has to do with that LDL that we're looking at?
I put COPD, potentially.
COPD, that's more respiratory, which yes, it may be, but that's gonna go more with like smoking and that type of thing. Yeah, heart attack.
Cardiovascular.
Yeah, cardiovascular disease, the word I'm looking for is atherosclerosis. Okay, atherosclerosis means like hardening, narrowing, building up of plaque in the vessels. Okay, and that's what causes your heart attack or your stroke or things like that. Okay, so from the high cholesterol, I've had a patient who had a central line, and when a patient has a central line, we draw blood, and I drew blood, and you could see the cholesterol. There is white chunks that will come out of your patient's blood if their cholesterol is so high. Okay, so there's atherosclerosis. So if you think of perfusion and oxygenation, it's nearly impossible because those vessels are full of cholesterol. Okay, so perfusion isn't happening. Okay? So atherosclerosis is that main term there. All right, let's take a 10-minute break and then we'll finish this and then start with the next one. And I'll pass it out during break so you guys have it. Okay. All right, so let's go through these scenarios. So the first one, you nurse gives thin liquids to a patient with dysphagia. Okay, who wants to tell me why that's wrong? Okay, Casey?
Because the patient should know if they can.
Yeah, because we just said if they have dysphagia, they need to be on thickened liquids of some types. Okay, so that's wrong. They're not giving them the correct type. And why is it unsafe? We're worried about what? Aspiration. Okay, so it's the wrong type of liquids. We're worried about aspiration. So how can we correct the mistake? Like I just said, we need to put them on thickened liquids. Okay, so that's how we correct it. And then the potential patient outcome is why it's unsafe is because they would aspirate if we give them that. Okay, so these ones are a little bit quicker. Okay, a patient with NG tube has a residual of 250 mLs, and then the feeding is continued. And I was looking with Sophia in your readings, and I was trying to find where you have this, and I could not find it specifically where we were looking. So you might just be getting it from me, and you might just be getting it from your notes. I'm sure it's somewhere, so I'll have to look. Maybe it's in your physical book, but I'll have to look, and I'll let you know exactly where it is. Okay, but when we check placement and all of those things, we aspirate the contents, and we use those contents to check the pH, right, to verify placement, make sure it's all in the same place. But residual is what's left in the stomach, so it's not moving from the stomach to the small intestine. So this patient is not digesting that food. So if we just keep giving it to them, they're gonna aspirate, it's gonna come back up, they're gonna be sick, they're gonna be vomiting, all of those things. So the cutoff is 200, which is still a ton. So we take a 60 ml syringe, a Toomey syringe, and we hook it up to the end of that NG or that PEG, and you'll be doing that in this lab towards the end. I think that's your last checkoff, is giving meds through a PEG tube for tube feed. So you'll be using this equipment and you'll be talking more about this then. But so we aspirate. Okay, so we check and we measure residual because maybe the feeding type, the different prescribed tube feeding doesn't work with that patient. Maybe they're not able to metabolize it. So the dietary or the dietitian would order a different type of tube feeding, or maybe they're getting too much or too fast. Maybe we need to administer tube feeding more frequently at a slower rate. So your patients can get tube feed continuously, or they can get bolus feeding. So we go in every few hours and pour some tube feed in. So there's different ways that we can get it into their system. Okay, but either way, we check residual, and that's what's in the stomach contents. So usually we barely get any in that 60 ml syringe. There's just enough to check placement usually. Okay, so if we fill that whole Toomey syringe all the way, that's 60 mLs. That's a lot that's just sitting in their stomach. So then what we're gonna do, we need to find out if there's more. So we would have our graduate container, you know, that triangle type cylinder container, and we would put their stomach contents into that container, and then we'd go back to our tube. Remember, we're gonna have chucks under them, we're gonna have gloves and all that, and we're gonna pull back more. And so if we fill it again, now we're up to 120, that seems like a lot. We're gonna put it in that graduate, we're gonna collect it all. We're gonna go back in, and we're gonna keep going until we can't get any more. And that's how we know how much total residual is in there. So if we have over 200 or up to 250, that is so much fluid that we're pulling out. Okay, side note, anything that we pull out of that patient, we put back in that patient. So after we've collected it all and we've measured it, we put it back in that patient, because we don't want to throw off, starting with tomorrow, we're talking about fluids and electrolytes. We're pulling out their fluids, their potassium, their magnesium, all of that. So we don't flush it down the toilet when we check residual. We put it back in that patient, but it's over the 200, which is the cutoff, so we would not continue this feeding. So as we're checking this patient, they're probably nauseous, they're probably bloated, they're probably not feeling good, they're maybe even vomiting at this point. So we would note that there's 250, we would put it back, we have to put it back because that's their stomach contents, that's their fluid and electrolyte balance, but we would not be continuing the feeding. Okay, so that's what the mistake is. What is wrong is that we continued. It's unsafe because it's too much residual. Correct the mistake is not continuing the feeding, and then the risk is that they're gonna be nauseous, vomiting, throwing up, all of that. They're gonna be very sick from continuing that feeding. Okay. The next one, warfarin, patient starts eating a large amount of spinach daily. So that's not very kind to just call them a warfarin patient. It should be a patient who takes warfarin or Coumadin. We've got a warfarin patient and they're eating large amounts of spinach daily. Okay, so again, you're gonna start to see some repetition. So the reason we choose the drugs that we choose to use as our examples when we're doing MedAdmin, when we're doing vitals, is because we know you're gonna see them come back around at the end of the semester and it's less new information for you. Okay, so we know some information about this already. So what is warfarin for? It's a blood thinner, okay? It's supposed to thin their blood. We give it to patients who've had stroke, MI, DVT, and AFib, like from our exam, to prevent them from getting those clots that can then develop as a stroke or as a PE in their lung, okay? And we talked about how the antidote to warfarin or Coumadin is vitamin K. Okay, we said vitamin K for clotting. Okay, and you may have noticed in your reading, vitamin K is one of our vitamins, it's one of our micronutrients, and spinach is like a very widely known food that has lots of vitamin K in it. Okay, so they're on warfarin, they're eating large amounts of spinach every day. It's directly contraindicated, it's working against the medication that they're taking. Okay, so it's wrong because that's not the type of food that they should be eating. They can eat a little bit here and there, but they shouldn't be like jamming their mouth full of spinach every single day, large amounts, because it's directly contraindicated. Okay, it's unsafe because now their blood isn't gonna be thinning like it's supposed to, so now they're still at risk for the MI, for the PE, for any of those, the DDT. Okay, correct the mistake, we would educate them to avoid large amounts of spinach, okay? So they can have their green leafy vegetables, but just not every day, and definitely not large amounts every day. Okay, and then the potential patient outcome is that they're gonna have the stroke, they're gonna have the PE, they're gonna develop the DVT that we did not want them to develop. All right, and then the last one, who wants to explain this one to me? Patient with BMI of 17 is placed on a calorie-restricted diet. Addie?
The BMI is 17, which means that they are underweight.
Yeah.
And if they're having a low-calorie diet, it will make their body weak and brittle with like the fingernails, and their hair will start breaking. And so we have to place them on a normal healthy diet so that they don't get malnourished or even die.
Yeah, so just a regular MyPlate diet. So we're gonna swap the calorie restricted for a MyPlate. And even until they reach that healthy weight, they can have the MyPlate and then extra stuff, okay? So you looked at that chart of calories and how many calories we're supposed to have based on our size and activity level. So at first, while they're trying to catch up, you could have them a little bit above that range, but then once they get into the healthy weight, then they can maintain that normal. It's about 2,000 calories, give or take, for a grown, healthy adult that's active. It should be about 2,000, give or take. All right, good job on that. All right, your next activity, I passed out to you. So it's just questions, so you're just gonna read the scenario, and there's 7 multiple choice questions. It's got some good information about some labs for you. So cholesterol, LDL, and HDL, and triglycerides, fasting blood glucose, and a hemoglobin A1C. Okay, so your cholesterol should be less than 200. LDL is like a type of cholesterol. In parentheses, it says bad cholesterol. To differentiate bad from good, I remember as LDL is lousy and HDL is happy. Okay, so HDL, good cholesterol that you get from eating like heart healthy foods like avocados and things like that. HDLs that you have in your circulatory system go around and like gobble up your bad cholesterol and help your body metabolize and excrete it. Okay, so we don't want to have too much of the cholesterol, the LDL, and the triglycerides, but we want to have enough of the good cholesterol from eating healthy food, from exercising regularly to do what it's supposed to do. Okay, so you'll see those normal values. Like for your exam, you would have something like this with the ranges, with the values. You're not going to have to memorize it. Just have to remember, what it's for, what it does. Fasting blood glucose. We've talked about blood sugars before, or AccuChecks. It's when we poke their finger and we see how much sugar is in their body. This one specifically is saying a fasting blood glucose. So it's when they don't eat anything. So the normal range is going to be a little bit lower, 70 to 99. And then we're introducing a new term. That last one is the hemoglobin A1C. And that's like a 3-month version of the blood sugar that's in their body. So we talked about how hemoglobin is part of your CBC. It's part of your red blood cells. It's the part of your red blood cells that carry oxygen through your body. Hemoglobin A1C is your hemoglobin that has sugar attached to it. So all of your hemoglobin in the body, if you're diabetic and it's uncontrolled, they're all covered with sugar. So so it's called a hemoglobin A1C. Okay, so it should be lower. So one of my patients that I did home health, different patient, I may have already told you this story. We were working with her diabetes. Her numbers were all over the place. Her diet was awful. She would help like babysit this old lady, and the old lady's husband would pay her in donuts. And so like it was a mess. Okay, so we were working and her blood sugars were all over the place. Okay, and then after several weeks, all of a sudden her log that she would show me every day was much better. Her numbers were in the 100s, things were doing good. She was like, yes, I'm exercising, I'm doing well. Well, then she went to the doctor and they checked a hemoglobin A1C. And this girl was lying to me. So I took her glucometer and I looked at the actual numbers and she was making up all of those numbers. Okay, so the hemoglobin A1C don't lie. Okay, so it's a 3-month average of what your blood sugar is. Okay, so every 3 months they'll go and see, and it should be, below 7 for that. Okay, so that's every 3-month lab they get. Okay, all right, so you've got a patient, history of type 2 diabetes, high blood pressure, hyperlipidemia, which just means high cholesterol. So those are those atherosclerosis patients where we go to draw their blood and we can see the cholesterol coming out. Okay, and that goes along with all those labs. Okay, so cholesterol should be less than 200, triglycerides should be less than 150, LDL should be less than 100, HDL should be less than, you'll see 50 or 40, depending on male or female, but your paper there, or over, should be over 40. So all of those numbers are bad for your patient. Okay, so you've got the medications, high intake of processed foods, red meats, sugary beverages. That's really the main killer for a lot of people because you think it's a drink, so it's not really gonna do anything. But that's like the #1 contributor to obesity is beverages. The #1 drink in the United States is pop, soda pop, any type of variety. That's the #1 chosen drink of choice is pop. Your body never needs pop, it's only ever extra and it's never good for you. So just something to think about for us and for our patients. And then they've got a sedentary lifestyle. Okay, so they're admitted for diabetes management, cardiovascular risk assessment. Healthcare team wants to focus on nutritional interventions to improve overall metabolic health. A registered dietitian, so there's another specialty staff member that we're gonna think about. All of our units have dietitians. They're great people. They can come in and give you information, educate your patient. Like I said, if your patient's on tube feed, they'll be the ones who order those specific tube feeds for your patient. The provider will consult with them if they have diabetes, high cholesterol, anything like that to help plan an appropriate diet. And then also, we were just talking about the hospitals have a diabetic educator as well. So if you have a patient who's unsure how to manage their diabetes, you might see that they have that consult, or that's something that you could recommend to the nursing team that maybe this patient needs to see the diabetic educator, and then you could hang out in the room and see what they do, what they talk to the patient about, what kind of information they give them. All right, for this one, these are pretty easy. These are multiple choice, so I'll just call on some people who haven't said anything yet. So let's see, Alexia, what'd you get for #1? Was it? Yeah, that's C. So if you just Google that calculator, put it in, that'll be 34.4. So that puts them in the obesity range. So risk for diabetes, which they already have, right? High blood pressure, heart failure, all those things. All right, which of the following describes Mr. Harris's lipid panels? Mary, what'd you get for that? Okay, all values within normal range? No, who wants to help her? Krista. C, yeah, the triglyceride and the LDL are elevated. Okay, so those are both bad cholesterols. They're higher than they need to be. And then the HDL, the only one that's good, so happy cholesterol, we want it to be above 40 or above 50, and it's too low. Okay, so that cholesterol does good things in your body. Okay, so we don't just want to completely avoid fats, but we want to have the right kinds of fats and the right amounts of fats. Okay, so looking at their lab values, if we go up here, total cholesterol, you can see normal should be less than 200, they're at 245. Triglycerides should be less than 150, they're at 220, and HDL should be above 40, and they're only at 35. Okay, so that would lead us to choose C. Triglycerides and LDL are elevated, HDL is low. All right, #3 then, which of the following is the most appropriate diet order? Virginia, what'd you get?
C.
Yeah, C, cardiac diet with consistent carbohydrates. Okay, so they've got all kinds of stuff going on. This is gonna be the one that handles all of those problems. So with the heart stuff and the diabetes, that's gonna be C. All right, and then #4, Caitlin, what'd you get?
C.
Okay, what is a key nursing intervention when implementing a consistent carbohydrate diet? Monitor the blood glucose levels before and after meals. So you may see this in the hospital depending on where they're at in their diabetes management. So like early on, there's lots of changes all the time and lots of monitoring Further on, it's less frequent monitoring. So standard protocol is AC and HS, which is before meals and at bedtime. But some patients you'll see also even after their meals, we need to check their blood sugar again. So they're getting poked 3 extra times during the day to see how that insulin's working. So we're trying to get their doses and their medications correct to control their diabetes. All right, and then this is a select all that apply. Which of the following foods should be limited or avoided in Mr. Harris's new diet? Try.
B, C, and E.
Yep, B, C, and E. Okay, so white bread, instead of we're gonna do whole grains instead of that. Fried chicken, okay, so if it was grilled chicken, that would be good. Fried chicken is gonna add all kinds of fat and cholesterol. And then a sweetened fruit juice, it just sounds like sugar, okay, so that's gonna elevate their blood sugar. Right, and then 2 more questions. Mr. Harris says, I've always eaten this way. Can't I just take more medicine instead of changing my diet? And like some of the students have already said, that's what you see. That is how the doctors are trained. They're hand in hand with pharmacology companies, and that is what you see. But that is not what's best for them. We don't want them to be on medications forever, unless maybe we own some shares in pharmaceutical companies, I don't know. But for their own best interest, with our nursing license, practicing ethically and non-maleficence and beneficence and all of that, we don't want them to be on medications forever. So what is the best choice here, Grace?
C.
Yeah, it's gonna be C. Medications to help, but diet and lifestyle changes are essential to prevent complications, okay? So the student was saying how he works on the surgery unit and he sees diabetic patients all the time, and it starts with injuries in their feet, and then it leads to amputations, and it gets up higher and higher. Well, they're on their medications, they're doing what the doctor is supposed to be doing, said they're supposed to be doing, okay, but it's not enough, okay? So diet and lifestyle, the goal is to get off the medications, okay? For a type 1 diabetic, they can never get off insulin, okay? Their body just doesn't make it, they will always have to take insulin. But for a type 2 diabetic, the insulin, the oral medications, it's not necessarily something they will always have to be on if they can make these changes. All right, and then based on the lab values and BMI, select all that apply. What are all of the complications that we're worried about? Gabby?
A, B, and C.
Yeah, A, B, and C. So stroke, kidney disease, vision problems. Okay, so you'll see these patients that are eventually on dialysis. A lot of them are kidney patients. And then the diabetic retinopathy, which we covered back in sensory. Okay, but for skin cancer, that's directly related to sun exposure. Yeah, so if we get done with the Kahoot early, you can work on them now, but if not, you still want to do those med sheets on metformin and atorvastatin, because those could be on the exam. Just like we had the 8 for the exam 3 that could have been on it. So far, after today's class, we'll have these 2 that could be on the exam board. Okay, and then we'll start tomorrow by kind of going through those. which nutrients supply energy in the form of calories and build tissue. Okay, so that's gonna be our macronutrients. That's carbs, which fiber is a subcategory of carbohydrates. So carbohydrates, fats, and proteins. Okay, those are all macronutrients. They all supply energy in the form of calories. Okay, so if we're counting calories, we would weigh our food in grams, fats, proteins, and carbohydrates, and then figure out how many calories we have. Or if you've taken your nutrition class already, in the front or the back of the book, there's a table with every single food, and even like fast food places and restaurants, and all you have to do is look up the food, and it tells you how many carbs, fats, proteins, vitamins, minerals, all of that would be in your nutrition book that you took. All right, so those are the macronutrients, and then the micronutrients are vitamins, like vitamins A and B, C, D, E, and K, and then our vitamins, and then our minerals or electrolytes, like sodium, potassium, magnesium, chloride, all of those. Okay, so vitamins, minerals, and then water is the third micronutrient. Okay, so unlike the macronutrients, they don't give us calories, but they help our body use the macronutrients. Okay, so if we just have all the macronutrients, no water, no vitamins, no minerals, our body doesn't have what it needs to make use of those macronutrients so they can do what they're supposed to do in the body. Okay, so they don't provide calories, but they help our body make use of the macronutrients. Metabolism is like how efficient your energy is. Okay, so when we're in periods of growth, so like little kids can usually take in more calories because their metabolism is faster. Their body needs it. We are no longer making new bones, new muscles. Really, for the most part, we are the size that we're going to be. But little kids are still growing, so they have to physically take the food and make it into new tissues. So they are going to need more energy. Their metabolism is faster because their body is very active. Okay. Also, when we're have an infection, we kind of touched on this with vitals and fever. Okay. So when we have a fever, our body's just running hotter. Our white blood cells are working and trying to get rid of that infection. So our metabolism is going to be faster when we have a fever and we're sick. Okay. And then epinephrine or adrenaline is the stress hormone. Okay, so if you have a lot of anxiety, you may see some patients who are more likely to be underweight if they have anxiety and those type of concerns. But adrenaline and epinephrine, and that's just the stress hormones in our body. And then also we give those like in a critical care or an emergency situation. If our patient's blood pressure is bottoming out, if their pulse is bottoming out, we'll give them epinephrine to try to increase those physiological activities in their body. So all options. Okay, what slows it down is going to be when we're sleeping. Our metabolism isn't as high as it is when we're up and awake because it doesn't need to be. And then as we age, so with our older population, they don't need as many calories. They just need to focus on nutrition. So when they fill their plate, they don't need as much, but they need to have nutrient-dense food. So more bang for their buck. So instead of choosing like empty calories, they want to choose healthy fruits, vegetables, and meats, all of that. That's going to be good, that's going to be true. That cholesterol should be less than 200, triglycerides less than 150, LDL less than 100. Okay, so 155 is a good cholesterol, should be under 200. Complications like poverty, homelessness, something like that. It is very easy to get fats in the American diet. Our vending machines and our fast food and all of that. It's harder to avoid fats. Right? drink. Soda pop is the number one drink, and that's loaded with sugar, which turns into fat. Alright, so if you remember from MedAdmin when we talked about oral medications and for them to be absorbed, that means they have to get into the bloodstream. And we talked about the portal and the mesenteric veins are the veins that takes things from your GI system and then into your cardiovascular system. Okay, so just like our medications, our foods are mostly absorbed and broken down in the small intestine, and we'll go through that when we do elimination next week. So to get all of that stuff from our GI system, because if it just follows the GI system, we're just gonna excrete it. So if we want it into our cardiovascular system where it can get to the rest of our body, it goes from that portal vein or mesenteric vein, from our stomach, from our small intestine, and then now all the goodness is in our cardiovascular system, or the badness. Of those three macronutrients, carbs, fats, and proteins are specifically involved with building tissue. Okay, so if your patient has a wound, then they're gonna be put on a high protein diet, or you'll see protein supplements on their tray to help grow that new tissue so that they can heal. Carbohydrates are most closely associated with energy because they break down quickly into glucose in the system, and then that's the form of energy your body likes is glucose. Fats are most commonly associated with like cushioning and protection of our body. They also are the building block of our hormones, so like growth hormones, stress hormones, sex hormones, all of that we need fats. And then all of our billions of cells that are in our body, the cell walls are made of fat or lipids, and so fats are very necessary for just normal day-to-day functioning. Yeah, so I said earlier 2,000, and again, it's gonna be more specific based on your height, your weight, your nutritional needs, your activity, but that's a good number to memorize. So a normal, active, healthy adult, the range should be about 2,000 calories a day. All options, so stroke we covered. Parkinson's we've talked before, but just a reminder, that's where they're shaking and they can't control. And it's very sad because it doesn't mess with the mind like dementia does. So they're very aware of their deterioration and they just cannot control. So it takes them a very long time to try to eat their food. So any of these patients, you know, sitting with them or even feeding with them would be a good intervention to help make sure they get their nutrition. So initial placement, so when we first put it down, and if you read in your book, you know, we take that tube that we're gonna put down into their stomach and we measure it from the tip of their nose to their earlobe to their xiphoid process, which is the bottom of the sternum, and we mark that tube. And that's where it should be at the end of their nares. Okay, so when we first put that in to make sure we didn't put it in their lung or we didn't not put it far enough or we didn't put it too far, they go for an x-ray. And then we confirm that it's in the right spot. The doctor will say, okay, the radiologist will say it's okay to use. And then once we have that initial okay, we can go ahead and use it. But then every time we go to put anything in it ever, we always check placement. And those other options are some of the ways that we check placement. So we're talking about it, thinking about it now. After IV stuff, NG tube placement is one of your first skills next semester. So you'll practice putting those down. At the end of this semester, you'll mess with pen head tubes and tube feeding. But NG tubes was moved. It used to be in this semester, but it was too much. You guys have so much and so many skills, so it was moved to second semester. Okay, but we don't check an x-ray every day because that exposes them to radiation. So it's just the initial placement. Okay, pretty good. Okay, so sometimes people get potassium and vitamin K mixed up. So potassium is one of our minerals or electrolytes. Vitamin K is one of our vitamins. Okay, so we have the addic vitamins, vitamins A, D, E, and K are fat-soluble vitamins, meaning your patient has to ingest fat to absorb those vitamins. And then we have the B and C vitamins, which are water-soluble, meaning they just have to be hydrated to be able to absorb those. Okay, so A, D, E, and K, and then B and C, those are our vitamins. And then the minerals are sodium, potassium, magnesium, chloride, all of those. Alright, pretty good. Trendelenburg is like upside down, like feet up, head down. So like if they're like passing out or their blood pressure is really low, you might see that in emergency situations. Or once you get into OB, you might talk about some Trendelenburg there. Discard into the toilet, I just went over. And then the green one, return the fluid back into the stomach, but it says without measuring. So the only one that's got the correct info is we're gonna measure its volume, which just means how much. The pH, and you'll practice this in lab, we have little pH strips, and so you would aspirate, put just a little bit in a med cup and make sure the pH is like less, around 6 or so. And then anytime we're messing with that tube, checking aspirate, which is stomach contents, or putting meds in or anything, we have to flush after, so we wouldn't clear it. So we wouldn't wanna leave the stomach contents in that tube, because it can clot it off. Okay, good. So that cutoff there is 24.9, and the 25 to 29.9 is overweight. We didn't talk about this specifically. See what you come up with. Pretty good. Okay, so I talked about how a tube feed could be continuous, especially if it's their only form of nutrition. Some patients get tube feed and eat, it's just a matter of them being malnourished, so they need that extra. Some people only get tube feed. So it can be continuous, or it could be bolus, like we go in every so often. So if we're doing bolus, you know, every time we go to access it, we're gonna check residual and check placement and all of those things. But if we never stop it, if we're always giving continuous, we still have to make some time to check and make sure that they're not getting overloaded, and it's every 4 hours that we do that. This was in the reading in like the metabolism section and in my notes in the metabolism section. So if we're working with a patient for weight loss, and we never want to educate a patient to lose more than a pound a week, that's really not very healthy. So 3,500 is the number for a pound of fat. So we can either have them, you know, 3,500 divided by 7 is 500. So if every day they consume 500 calories less, like if, you know, the first step is doing a food diary and seeing what they're ingesting. We say, okay, starting next week, every day I'm gonna do 500 less. By the end of the week, they would lose a pound, or maybe they're keeping track of their activity, and they say, every day I'm gonna have 250 less, but I'm gonna burn 250 more also, so with walking or whatever it might be, so same result at the end. Okay, so this is just talking about metabolism and healthy weight loss. Perfect. Just choose the one that's not listed, there's right there. All right, glycemic index, if a food has a high glycemic index, it means that it raises the patient's blood sugar very quickly, but then it drops down low. Okay, so it's very unstable. If it has a low glycemic index, it provides slow and steady energy for the body. So like a canned fruit, cookies, french fries, all of that will have a high glycemic index, so it hits you quickly, but then there's no like fiber, good stuff in it, so it's gonna bottom you out pretty quick. Chickpeas are a really nice healthy snack. If anybody likes buffalo chicken dip, does anybody love buffalo chicken dip? Like I said, my husband's allergic to chicken. You can substitute chicken with chickpeas, and it's actually really delicious and really good for you, so try it out. So chickpeas are good. I have several delicious chickpea vegetable, or recipes, if anyone's curious. This one with like lemon and Parmesan cheese. Alright, and then combining some mineral and vitamin information. So calcium is one of our main minerals for healthy teeth and bones. And our body also needs vitamin D to help make use of that calcium, which we get from the sun or from fortified milk or things like that. Right, top 3 can come get something. We're done for the day. I'll take your name tags. You're gonna keep those. And then starting tomorrow, we'll look through the atorvastatin and the metformin sheets. Okay, and then we'll get into fluid and electrolytes.